as they would see in an actual setting. So this is our agenda, and it'll run through 8 o'clock today, or so that's the hope. We are going to try our best to stick to the timeframes that are listed on our agenda. So as Austin was kind enough to tell us in the chat box, he will give a little warning, a 1-minute warning in the chat box, and when the time is up, a little ring or a phone ring will notify us that the time has been expired, so we can keep on schedule given the number of specialists that we have on panel. And so we want to keep to those timeframes. So with that being said, I'm going to give a brief introduction to our topic for today, liver cirrhosis. Essentially, it's an end-stage liver disease. There are many things that can cause it. Some of the more prevalent causes of it include non-alcoholic fatty liver disease, chronic alcohol abuse, viral hepatitis B and C, and essentially is a chronic insult leading to fibrosis and regenerating nodules. It can present with many symptoms, including portal hypertension, decreased detoxification that results from the liver being unable to function at its full capacity, and impaired synthesis because of the same reasons. Some of the complications that can be caused by liver cirrhosis include portal hypertension, hepatic dysfunction, and lastly, hepatocellular carcinoma in an end-stage liver cirrhosis patient. So with that, I'd like to hand it off to Dr. Danko, who is an addiction medicine specialist, who will brief us on her perspective for someone that might be prone to getting liver cirrhosis. With that, Dr. Danko, if you would.
Hi, can you hear me okay?
We can, thank you.
Great. Well, thank you so much for having me. What an exciting panel, and how nice of everyone to join. Seems like you have a great turnout. So I am double boarded. I'm board certified in internal medicine. I went to med school in Reno, right where you guys are. And I also became subsequently certified in addiction medicine, basically by a practice pathway in 2017. So I just want to introduce this just with a couple minutes to say, alcohol use is common. You're going to realize this whether you're first through fourth year, or regardless of what residency program you decide to embark upon. You will notice alcohol use is common. It often goes undetected. We often don't even ask about it. It can cause a lot of shame. And I will say it worsens pretty much every health problem that you will see, whether it's medical or surgical. And people are often more open to change regarding their use of alcohol than we would expect. So don't just put alcohol questions into this social history. Do you smoke? Do you drink? Do you have a cat? Yes, those are social history type things, but treat alcohol use disorder and drug use as a chronic medical condition that can really be approached with compassion. And they do have really successful treatment modalities. Alcohol use disorder itself is actually defined by the DSM-5 as characterized by problematic patterns of alcohol use leading to a significant impairment or distress manifested by multiple behavioral, psychosocial, and physiologic features. So you can look at those criteria on DSM-5 if you'd like to, but the technical term for someone who has alcohol addiction is alcohol use disorder. And we often see that alcohol use disorder and substance use disorders are widely undertreated. So hopefully towards the end of this panel discussion, I can hint a little bit about how we can approach these patients and how we can offer them compassionate treatment options. And I'm always available for questions. Hopefully I didn't go over the time.
You did not. Thank you for that.
Of course.
All right. So with that being said, Dr. Danko would typically see these patients who might be getting treated for alcohol use disorder. And our case takes us to the next step of how this patient might present to the emergency department. So with that being said, this is part one of our presentation of liver cirrhosis. So a 55-year-old male patient with a history of alcohol use disorder presents to the emergency department with hematemesis. He reports increasing fatigue, anorexia, nausea, and melanoma over the last month. Previously, he was hospitalized for alcohol intoxication and reports drinking 6 to 12 bottles of beer per day. His blood pressure is 100/50 and heart rate's at 105. Physical exam reveals abdominal distension, scleral icterus, and mucosal pallor. And what do you do after this? With that, emergency medicine with Dr. Ingelspie. He will brief us on this. Hello, Dr. Ingelspie. Thank you for joining us.
Everybody, thanks for taking the time. I appreciate the invitation. I'm one of the ER docs now in South Meadows. I went to med school.
Dr. Ingelspie, I'm not sure if it's just me, but I think you're breaking up. I'm not sure if it's only on my end, or can everybody else hear Dr. Ingelspie fine? No, it seems like everyone else is. Can you try again, please?
Yes, thank you for the feedback. Let me see if that's any better. I'm getting a couple thumbs up. Awesome. Sorry, guys, the AirPods are not working tonight. So thank you, everybody. Again, my name is Graham Inglesby. I'm one of the ER docs at Renown and at South Meadows. I went to med school at the University of Miami. I trained in emergency medicine in Denver and have been working here in Reno for the last 3.5 years. I will be brief. There are much smarter people on the panel than myself, but the brief introduction is that with a cirrhotic patient, especially with the presentation given to us, the big thing quickly in the ER is this an ABC patient or an H&P patient? So that kind of question we ask in the ER a lot, sick or not sick. This patient's pretty sick. As much as they sound stable, they're tachycardic, their blood pressure is soft. And so I need to make sure right away that the patient is protecting their airway, that they have adequate IV access, and that we are going to make sure that we are leading to the appropriate interventions that we need to address immediately. As you can see on the slide here, obviously with a patient with known alcohol abuse and clearly clinically looks cirrhotic, the first and worst thing we have to worry about is variceal bleeds. Why are variceal bleeds bad? Well, they're pretty much about the sickest patients that you can find. They come in already with end organ damage. And if you think of a varix, which is that pressure buildup from the liver, venous blood flow, think about it in the maybe 10 to 20 millimeters of mercury range of pressure. As varices build up over time, that pressure goes up to 40 or 50. And so then if one pops, it's essentially an arterial bleeding patient. This is like a trauma activation red patient. They lose blood fast, they're hard to control, and it's a hard place to put your finger on the bleeding. So the things that we worry about in the ER immediately, obviously varices, and we'll talk a little bit about the management of that. Every single cirrhotic patient that comes into the ER, especially with abdominal distension, it's my job to rule out spontaneous bacterial peritonitis every time. I don't care if they have a fever, I don't care if they have a white count. It's my job to make sure they don't have SBP, because that's a very life-threatening condition. Hepatorenal syndrome is an end-stage complication, but very sick patients, and you have to start thinking about multi-organ systems. All of these patients are at risk for sepsis, particularly from gut flora. So gram negatives are the big killers in these patients. Hepatic encephalopathy, as much as it's not always too much to manage and something that takes days to get better, at times can lead to obtundation where a patient is not protecting their airway well enough. Unfortunately, these patients do have the disease of alcohol abuse and addiction. And so even though they have end-stage liver disease, they may still be drinking. And so we have to also think about hemodynamic stability in regards to alcohol withdrawal as well, which complicates everything. These patients are often confused, sometimes intoxicated, often dehydrated, and fall a lot. So if you see any evidence of head trauma in these patients, guess what? They need a head CT to make sure they don't have a subdural that's been brewing for days, weeks, or months. Portal venous thrombosis, another thing that is often missed in these patients, but they can often throw clots. And so that's a very important emerging complication to make sure you address, as well as just concerns of, hey, maybe is this a liver failure patient, but it's turned into HCC, and they actually have malignancy and maybe mets and other organ systems that are complicating their presentation. So as a quick overall, that's the big things that we have to think about in the ER. How do we care for these patients? Right away, again, that ABC business that we're obsessed about in the ER. Minimum 2 large bore peripheral IVs, airway management. If the patient's not protecting their airway, or if they need an emergent intervention, it might be the right thing to intubate the patient. Often these patients are getting up to 5 or 6 different infusions, so you're probably going to be putting a central line in these patients. Labs, nothing surprising. LFTs, you want to check their electrolytes, you want to get a CBC, mainly to look at their platelets, because these patients are often profoundly thrombocytopenic, but can also be quite anemic, especially in the patient in the presentation that Arda put forward with a month of melena. They could be critically anemic. Ammonia will help in determining their degree of encephalopathy. Doesn't change a lot in the ER. One thing to think about, just to be put in everybody's minds, because in emergency medicine we have to worry about it. If it's an acute liver failure, always think about just sending a Tylenol level. Maybe this is an acute overdose, and that's one quick miss that you don't want to miss. Think about blood cultures in these patients. Again, very infectious prone. Type in cross match. They might be getting blood and other blood products. And again, ascites fluid analysis, looking mainly at cell counts. If it's a first-time diagnosis, looking at things like their ascites albumin level and those other studies. Imaging, I will quickly pull a little ultrasound machine into the room and see the degree of ascites that you often know based on your clinical exam. If their belly's up to here and it's tense and firm and you feel a positive fluid wave, guess what? There's going to be a lot of ascites there, but it's nice to confirm, and also something you're going to use to guide your bedside paracentesis. It's also a good thing to look at their overall volume status. So with these patients, especially if hemodynamic instability is involved, I'll do a quick echo, look at their IVC, look at their volume. I will often get a consultative ultrasound with Doppler to evaluate for a portal venous thrombosis. And further imaging as indicated. Again, if I see head trauma, get a head CT. If anything else is going on, image as needed. Treatment. If this is a bleeding patient, if they are actively bleeding and they are unstable, you're going to start a proton pump inhibitor, bolus and drip. You're going to start octreotide. The medication that's been shown to help with mortality the most in these patients emergently is actually ceftriaxone. Again, that gram-negative gut flora leading into the bloodstream. And then plus minus, if they're super sick, you might be starting a massive transfusion protocol on this patient. If you're doing a large volume paracentesis, once you cross about the 4 to 5 liter mark, you have to think about an infusion of albumin, because patients can really drop their blood pressures. They might be stable, but if you take all that fluid off, there's a lot of fluid shift, and you might need to give them albumin, and obviously fluids and pressors as indicated. Consultation, obviously you want to talk to GI if these patients are super sick. They are probably ending up in the ICU, at least for close monitoring and possible further interventions. And at times, even IR. One thing I didn't touch on in my slides, and I'll just do a quick note on that we do in the ER rarely, but occasionally. I actually had a case last month where we had to place a Blakemore, also known as a Minnesota tube, where if you think, again, this is an arterial bleed internal to a patient, hard to get to spot. We have a tube with gastric and variceal balloon that we can actually feed into the patient after they're intubated, protect the airway, and try to inflate pressure into the stomach and tug back, and then potentially also inflate pressure on the esophagus to give direct pressure, because the best fix for active bleeding is direct pressure. That is a rare but sometimes indicated procedure for variceal bleeders that are quite sick. And yeah, that's what I have from the ER standpoint. And thanks for the time, everybody.
Okay. Thank you, Dr. Gillespie. That was very informative. And before we move on, I just want to remind everyone, if you do have any questions, because there's going to be a lot of information thrown at you from so many specialties, just go ahead and jot it down for yourself. We're going to have a Q&A session at the end. You'll get a chance to ask your question. All right, let's go to our next slide here. Okay, so emergency medicine, excuse me, that was not supposed to happen. Emergency medicine orders that GI consult, and the patient is admitted to intensive care unit. With that, Dr. Yamamoto, I'm not sure if I saw Dr. Yamamoto join us. Is Dr. Yamamoto here yet? Perhaps not.
Yes, he's here, Arthur.
Is he here? Okay, I must have missed him.
Denny. He's under Denny.
Okay, Hello, Dr. Yamamoto. If you can go ahead and give us your perspective on this. Thank you.
I think he's still muted.
Dr. Yamamoto, I think you're still muted, sir. If you
Better
can.
now? Am I better now?
Yes,
Yes.
we can hear you now.
Okay.
Welcome.
Thank you for inviting me. I think Dr. Danko invited me because I'm the oldest gastroenterologist in the community, and I've seen treatment for this disease endoscopically grow from my first scope that I completed in 1980, which a lot of you aren't even born yet, to what we do now. So the interventions that we can do to help patients like this to prevent or stop their variceal bleeding or just GI bleeding and acute GI bleeding with all this intervention now endoscopically is phenomenal, just phenomenal. So just a side note, all of these students get to know how to deal with these patients because there's going to be a lot more of them. Liver disease is going to be a big part of your practice moving forward. The next 50 years, you're going to see a lot of patients with this. Maybe not alcohol, but fatty liver disease is going to throw a big blanket on hepatology, and you guys are going to have to know how to deal with this. So this is going to be very commonplace for you, unfortunately, moving forward. But having said that, Dr. Inglesby and crew will call, we'll respond. By that time, most everyone is stable. People are airways managed, vital signs are as good as they're going to get. I then, if I deem that endoscopy is necessary, which 9 out of 10 times it needs to be done, to make a diagnosis and then see whether we can treat it. So making a diagnosis, seeing where you're bleeding, intervention endoscopically is key. So a patient has to be stable. So airway management, again, making the patient as stable as possible and getting the patient sedated enough, which you may need anesthesia to do this. They may have to help protect their airway. You may need to have enough anesthesia on board so you can do this visualization adequately. Now remember, when you get airways controlled and you put the scope down in here, you may just see a sea of blood. You may just see everything just covered with blood. And so you have to be meticulous in looking at things and getting things cleared out. May have to suction and wash things out. And the picture that you have that you see on this in the slide is actually a very good representation of that. You see these big dilated veins in the esophagus, and this is very abnormal. You need to, side by side, you put in the regular esophagus, a normal esophagus, it doesn't look anything like this. So this is huge dilated veins, and there are signs, the big purple signs, and then there's varices on varices. In other words, you see little purple marks on top of the varix. They're called whale signs and varices on varices. These mean that there are additional pressures on the vein, and the likelihood of these things rupturing and bleeding is very, very high. When you do the scope, we make sure we try and find out where these places are bleeding, and literally you can see it spurting. They'll actually spurt, and it almost to the point where you can actually feel their pulse. And you get down and make sure this is the only place they're bleeding. In other words, people that drink a lot also have peptic disease. So you can actually have lice and fleas. You can have ulcer disease and variceal bleeding at the same time. Again, we now have the tools to intervene on these. We have capacity to put literally hemorrhoidal banding devices that have been modified to be put on the end of a scope. And we actually get down on these varix. We suck the varix up in this device, and we then release a rubber band that strangulates the vein. It's been very effective. It's probably the most effective thing that we've developed to control the bleeding, and has really changed the whole field of getting variceal bleeding under control. So really quick intervention, know what you're doing, take a look, and make sure they're not bleeding from someplace else. A lot of nuances, lots of things to learn about how to clear out the stomach full of blood, but resuscitation, the whole time you're doing this, patient's probably receiving blood, may or may not be on a ventilator. All these things need to be considered. Now, the other side note to all this is figure out whether you're dealing with somebody who has chronic disease or somebody who has an acute disease. In other words, there's certain physical signs you guys need to pay attention to. Spiroangiomata, gynecomastia, testicular atrophy, duplicunch contractures, capilla medusa, dilated veins on the umbilical area. Those don't happen overnight. So you see somebody with these subtle signs, you got to say, okay, I'm dealing with some of the chronic liver disease, because you're going to prep yourself for what you're going to find when you're looking here. If you don't see these things, the mind's got to think a little bit differently, that maybe this is not the problem. Peptic disease gets higher in the list. So use your physical findings and history, obviously, but physical findings and say, am I dealing with something acute on a chronic patient, or there's something acute on somebody who's otherwise been pretty stable? So kind of look at, don't forget the physical signs. You guys got to look at that. So we're pretty good. Sometimes we don't all get to this. So I guess there's somebody with the interventional radiology is going to talk about tips.
Excellent. Thank you, Dr. Yamamoto, for the information, and we'll be moving on. And with that, internal medicine with Dr. Callister.
Well, thank you for having me. I'll be quick in my introduction. My training, in the interest of time, education, and training was Stanford, Utah, and UCLA. And like Denny, I'm getting to be an old timer here in town. I tell my interns who are PGY1s, I'm now a PGY 33. So, adding to the years. We take over in the hospital side of medicine when the ER starts to hand over. And I really liked both Dr. Yamamoto's and Dr. Ingolf's presentations, because the first thing you have to do is decide, is this guy going to die on you? I mean, looking from the door is critical. Those subtle signs for chronic disease tell you if it's been there a long time, as Dr. Yamamoto just went over. And then you also need to look for, what are the signs that this person's going to crash out and die on you? What you heard earlier during the ER portion referred to as the ABCs versus the H&P. So unlike physicians in the office, when we're in the hospital, we don't have the time to assess everything before we act. So we use a lot of empiric therapy, and that's been alluded to from the first couple of speakers. So when I'm looking at somebody in the ER like this, or they're first heading towards the ICU, I want to know, are they hemodynamically stable? That 105/70 blood pressure might be a little soft. It might be normal for this guy. And if we have some old hospital records, we may be able to tell that. When we're looking at his blood pressure, when we're looking at his mental status, are there other signs of decreased perfusion? Always remember, in these liver patients, there's a big difference between total body volume and intravascular volume. What you really need to assess is intravascular volume and how rapid this bleed is. Is it life-threatening? If this bleed is rapid and life-threatening, before we even get to the possibility of these wonderful interventions that skilled GI people like Dr. Yamamoto can do, or even considering any kind of surgery, that patient has to be hemodynamically stable first. So we're going to be looking at what number or what amount of packed red cells we may have to put in. We're going to look at coagulopathies and what do we need to do to reverse the coagulopathy, or they're going to keep bleeding. And coagulopathies will require things, not packed red cells, but things like fresh frozen plasma, cryoprecipitate, the 4-factor concentrate, all of those kinds of treatments. We need to look at the platelets. If the patient's actively bleeding and well below 50,000 platelets, transfusion of platelets come into the mix. So there's multiple things that have to enter your head at the same time. When we move beyond just intravascular hemodynamic stability, you heard a little bit about infection. Is this patient decompensating due to infection in addition to the bleed? Acute GI bleeding is one of the biggest risk factors for developing SBP, spontaneous bacterial peritonitis. So that antibiotic is not only important because of the GI bleed in the context of liver disease, it's also important empirically until you're sure you don't have SBP going on. And that's where the tap of the belly comes in, if not therapeutic, at least diagnostic. If you don't think the patient is stable enough to handle a high volume paracentesis, you should still be doing a diagnostic to find out if SBP is in play. And all of these things need to be happening in real time, simultaneously, not one after the other, not tomorrow morning. And this falls into the category of need to know when to walk and you need to know when to run. Once somebody's stable, stability and empiric therapy are underway. Maybe they're on octreotide and a PPI. They've received blood products. We're getting Dr. Yamamoto to get ready to scope him. He's stabilized. We've given blood products. The platelets are up. The INR is better. The hemoglobin stabilized. Now we start to look at further diagnostics and reassessment. Is this patient, do they need to be in the ICU? Should they be on the medical floor? Were they really not that sick after all? What's their risk of mortality in the near future? You'll read about things in the interest of time. I can't go into it, but the MELD score and the child Pew score. There are certain categories where we may be talking about liver transplant while the patient is still an inpatient. We may be talking about a transition to a liver transplant center. And then once we do reassess, we need to be very, very careful that further therapy does not worsen the patient's condition. In other words, we don't want to do something that harms them after we just stabilize them. Good example, beware of hepatorenal syndrome. If the patient has a creatinine that's bumped more than 0.3 or more than 50%, they're at very, very high risk for developing hepatorenal syndrome if you go in there and take off 6 or 7 liters. So keep that in mind as you assess these patients. You need to walk fast, and then you can slow down and start to reassess as you stabilize them. But you also have to think about everything at once, not one thing at a time. Thanks a lot.
Great. Thank you, Dr. Callister, for that. All right, let's go to our next slide here. So at 36 hours, patient rebleeds and requires blood transfusion. Internal medicine orders a IR consult for that. And with that, I'd like to hand it over to Dr. Vogel, who's an interventional radiologist. Dr. Vogel.
Hey, good evening, everyone. Thanks for having me. My name's Alex Vogel. I'm one of the interventionalists at Renown. I've been here for 6 years. I was in practice in California for 4 years before them. And I am a self-described tips enthusiast. And the first thing that I want to convey about tips is it's critically important that you spell it correctly. I see a lot of notes in the charts that have 2 P's or may have 2 S's. That's a catastrophic error in my book. Okay, it's a transjugular intrahepatic portosystemic shunt. I don't know where 2 P's ever come from. I think sometimes the 2 S's come from systemic shunt. But remember, portosystemic's one word. So the spelling of TIPS really describes what it is. And in this diagram that's shown here, it basically lays out how simple my job is compared to what everyone's done to save this person's life before they get to me. All right, Dr. Callister has to deal with 1,000 things at once. Dr. Yamamoto and Dr. Inglesby, they have to deal with a huge differential. My job, when I get this patient on my table, is to create this shunt in image C between the portal circulation and the systemic circulation. So that shunt up north, the top of the liver, it's going from the right hepatic vein to the right portal vein in a nice smooth arc. Now, frequently when I get these patients, a lot of things have already been done to make my job a lot easier. Almost always, they're all already intubated and I have nice control of their breathing and their overall hemodynamic status. That's super important, super helpful. There are lots of tricks in the literature that describe various ways of guiding the puncture that I have to make from the hepatic vein to the portal vein. But the thing to remember when you send these patients my way is a TIPS procedure at its core is an exercise in hepatic fenestration. I take a 5-gauge sheath needle, or sorry, a 5 French sheath needle or a 16-gauge spear and just jab it in the direction I think the portal vein is. So I greatly prefer that the patient at that point not be terribly coagulopathic or terribly thrombocytopenic, but I'm not going to sit around and wait for them to die while that gets corrected. So having smart people upstream from me who are already dealing with this is just absolutely critical in getting this done. The other points I'd like to make in terms of patient stratification, certainly the MELD score or the MELD sodium score now comes into play with some patient selection for TIPS. I almost always ignore it in my practice when patients are bleeding, because these patients almost always have no other options, and acute GI bleeding can throw the MELD calculation out of whack by artificially elevating the bilirubin before where it would have been, above where it would have been. The MELD does come into consideration when you're looking at bringing someone in for a more or less elective TIPS in the setting of chronic ascites, but that's not the patient we're dealing with here. The one other note I would add to the discussion that we've heard so far is that I don't want to get a call when this patient is acutely bleeding or rebleeding. I want my call after the patient is initially stabilized. There is some data that's pretty good. It was good enough to get published in the New England Journal, which is extraordinary for an IR paper, that suggests that TIPS after endoscopic stabilization, but before they're discharged from the hospital, has a substantial positive impact on overall survival and decreased subsequent hospitalization in these patients. So there's a lot of work that has to be done before I see these patients. I don't want to be anyone's first call, but I want to get called about basically all these patients. Couple more points. There are other options that we have at our disposal. They are somewhere between real additional options and curiosities. So if we do wind up in a weird situation where a patient has variceal bleeding and they might benefit from a TIPS, but they seem to be a terrible candidate for whatever reason, there are other things we can talk about. So again, call me, we can talk it over.
Excellent. Thank you, Dr. Vogel, for that perspective. Now, at this point, the patient is discharged in stable condition and he is advised to follow up with his primary care and GI, but he doesn't show up to his scheduled appointments, which brings us to part 2 of our presentation, hepatocellular carcinoma. So patient returns to the emergency department 2 years later with an increasing abdominal distension and shortness of breath over the past couple of months. Vital signs are stable. Physical exam findings reveal shifting dullness and dullness to percussion in the lungs. Paracentesis reveals high serum ascites albumin gradient. Abdominal CTA reveals a 1.5 centimeter lesion enhancement in the arterial phase and a washout in the portovenous phase. The patient is admitted to the floor for management of his ascites and suspicious liver lesion. So what do you do at this point? And with that, Dr. Vogel again is going to give us a brief on the imaging side of this for hepatocellular carcinoma. If you would please, Dr. Vogel again.
All right, thank you again. So on the side of treating other chronic complications of chronic liver disease, certainly diagnostic imaging plays a role in identifying tumors. And there are various screening parameters, mostly done with ultrasound, to detect tumors early and in outpatients in patients who are living with chronic liver disease. Ultrasound is great as a screening tool. It's fast, it's inexpensive, but once you see that someone has a goober in their liver, they're going to wind up getting a more advanced cross-sectional imaging modality. And almost always what we will do is a so-called hepatic mass protocol, CT or preferably MRI, in order to find the characteristics of liver tumors, which show some dynamic variation in the appearance. So in image A here, that's the unenhanced CT image. You just see this vague hypodense area in segment 2 or 3 of the liver. And then in the arterial phase of contrast in series B, you see some pretty early, though subtle in this image, peripheral enhancement that persists on the more delayed images in C and D. So you have an arterially enhancing lesion with a capsule and some washout. And what I've provided on the right is a diagnostic algorithm and rubric that's been created by the ACR to help us describe these consistently. And rather than concerning yourselves with the specific features and characteristics, the important things to know here are that things that are mass-like, may be invading a vein, show a capsule washout or arterial phase enhancement, are fairly characteristic of hepatocellular carcinoma.
Great, thank you again, Dr. Vogel. And with that, internal medicine, Dr. Callister will give us a rundown here.
All right, thank you again. Well, in the interest of full disclosure, one of my big academic interests is what we'll call care transitions. Where should the patient be placed? And how do you know using objective criteria? So before we get into the details of this workup, reading that second presentation 2 years later, I need to start out getting you thinking about appropriate use of resources. I don't know that this patient would be admitted to the hospital. If they were stable and their oxygen sats were okay, they'd probably get a paracentesis in the ER. And even with these findings, may be referred for further workup as an outpatient and workup with their primary care internist, their gastroenterologist, and then referral to IR for biopsy or to the hepatic surgeon like Dr. Gallinopoulos. So just keep that in mind. That's not an automatic admission to the hospital at all. If the patient looks like there's a stability issue, if it looks like they may be at risk for spontaneous bacterial peritonitis, and we do the TAP, the paracentesis in the ER, and it looks like they are indeed infected. If their ascites is such that they're having oxygen desaturations and poor inspiratory efforts, reduced lung volumes, all of those kinds of findings, what we'll see in acutely decompensated liver disease rather than compensated liver disease, then yeah, they'd probably get admitted. And then when we decide whether or not to go to the medical floor or the ICU, it comes down to whether or not they're sick enough to be in the hospital, with meaning they require diagnostic and therapeutic treatment now that they could not get in a timely fashion as an outpatient, or they're high risk for deterioration. And then if they're hemodynamically unstable or at high risk thereof, you'd go to the ICU. So first and foremost, as we worry about this tumor, we're also worried about what's going on right now, because that's an internist hospitalist job. Are they GI bleeding with this again? And it hasn't been picked up yet. Do they have spontaneous bacterial peritonitis? What's their renal function? Is their creatinine climbing? And once again, they're at risk for things like hepatorenal syndrome. So we're always looking for these complications that are going to make somebody seriously ill or kill them in the short term. And after that, once we decide that the patient's stabilized and we don't have to do anything more hyperacute, as I might say, that's where folks like our interventional radiologist may come in, and we'll be talking to gastroenterology and also at this point, surgery. The diagnostics are pretty straightforward. A lot of the diagnostics are going to come, as you mentioned, or from the case presentation from the ascites fluid. I would mention, though, you said this patient had a low serum to albumin gradient. That's more consistent with cirrhosis, CHF, TB. We tend to see a high gradient in malignancy. So is that gradient more consistent with decompensated liver disease? Doesn't mean they can't have a hepatocellular carcinoma as well. And it probably does. But ascites findings are more consistent with decompensated liver disease rather than malignancy. That being said, let me finish with the take-home point for that. Is we always want to get one great diagnosis, put it in a box, and tie a ribbon around it. And those of us who have been around a long time, I know Dr. Yamamoto will agree with this, things are usually multifactorial, and there's usually multiple things going on at once. So you have to remember that. So even with, and I see in the chat, they said, sorry, they meant to say high SAG. Okay, low SAG is consistent with decompensated cirrhosis, CHF, et cetera. It still doesn't mean that this isn't a tumor, especially based on the radiology findings. So I would argue the patient has both based on the ascites finding. So I think I've pretty much used up my time there, so I'll thank you and let the others move on. But I will say one more thing. We usually don't consult, and I'll be interested to see what the oncology says. We usually don't consult oncology until we actually know what we have. Often, after the biopsy and we get the pathology back. So that's a matter, again, of resource utilization and not wasting people's time. Thanks.
Great. Thank you again, Dr. Callister. And with that, we are going to explore our surgery options with Dr. Galanopoulos.
Hi there. Can you hear me okay?
We can. Welcome, Dr. Galanopoulos.
Okay. Thank you. Forgive me for the background noise. I had to run to the hospital, so I'm in the car heading back home now. But so I was looking at the films that just were presenting the case that you have a tumor in the left lateral segment of the liver. And, nowadays, compared to what we used to be able to do for cirrhosis is much more extensive. The biggest lesson we learned probably 10 years ago or more is that local regional control is the optimal treatment outside of transplant. And so when we get patients who we get called about who have cirrhosis, who have tumors that on MRI or CT or both will have characteristics of HCC, we have signs of cirrhosis on imaging, including nodular livers, large spleens, varicosities, collateralization, large portal vein. Sometimes we get portal vein thrombosis. When we see that, we actually don't necessarily need a biopsy. The AFP is important, but a lot of times, as many people have seen, that the AFP comes back normal. There are two other tests that we like to do called an AFPL3% and a DCP. These are all available serum tests, and they are a little bit more sensitive, meaning the AFPL3 is sensitive and AFP, and you might have an AFPL3 or AFP, and that helps singe it. When it comes to tumors of the liver in people with cirrhosis, what is unusual is that you don't find many people with it. So you'll
Dr. Galanopoulos, I think your phone might be breaking up.
Yeah.
I think your phone might be
sorry.
breaking up. We cannot hear you well.
Shoot. Can you hear me better now? I'm getting close to the signal, hopefully. Hello?
It's still the same. It's still breaking up.
Hello?
Chris,
Okay.
this is Suji. You're breaking up. I can take over if you want me to.
I think he may have even gotten his call dropped because I don't think I see him here now. What we can do is we can come back to his slide. We can move on to our next slide and we can come back.
Dr. Callister, Dr. Chowdhury could pinch hit for him.
Okay, all right. Hello, Dr. Reganti. Thank you for joining us. If you don't mind, if you
Yes.
Dr. Chowdhury, yep.
Did Dr. Galanopoulos log in again, or is he done?
I don't see him here,
don't-
so I
okay.
believe he might have been dropped.
Yeah. So I can take over and I can kind of like explain to you guys what he's trying to tell you. So whenever we see an isolated liver lesion, anytime you see an imaging study that shows like a suspicious for malignancy, usually we get a call as a medical oncologist. So it is, hepatocellular carcinoma, we don't really do a biopsy for this one because based on the imaging studies, that's what Dr. Galanopoulos was trying to tell you guys. Like, no, we commonly like don't do biopsies in these individuals based upon their clinical status, based upon their MRI findings, based upon the vascular involvement and all that. We can just make. Is he back?
Yeah, I'm back, Suji. Hi.
Oh, okay. I was going to take over your.
Sorry.
I knew where it drops.
Thank you.
Go ahead. Yeah.
Thank you, Suji.
Go ahead.
Okay. Sorry about that, everybody. I got a much better signal now. So, so as we were saying, hopefully you heard about the AFPL3 and DCP. What Dr. Reganti was saying is that we don't normally do a biopsy. If we have characteristics on imaging, cirrhosis, all that, we go with the diagnosis that it's an HCC. I was getting into the point of that. When we look at liver tumors, one of the reasons the biopsies, if you're not sure what type of liver tumor, is it a benign FNH, an adenoma, Is it a cholangio? Is it metastatic disease? And we don't see metastatic disease in cirrhotics or cirrhosis much. It's very unusual. No one really knows why. I suspect it's related to portal hypertension and the fibrotic nature of the liver, that it doesn't allow tumors to invade very well. But in any event, when we do have that, someone calls, says, hey, we have a HCC, can you come take a look at it? What Dr. Arganti was looking at and discussing was that we could use, we want to find out, is there vascular involvement? Is there portal vein thrombosis? Is there hepatic vein involvement? How large is the tumor? But going back to basics, if you remember during your physiology classes, we look at liver disease and the extent of the liver disease. That limits what we can do. So if someone is a child's A, if everybody remembers a child's class A, B, and C, class A will be someone who's at low but moderate risk of some significant morbidity, but a lower mortality. When you get to B, your mortality rate for any major abdominal operation is between 10 and 15%. And when you go to C, those people are essentially unresectable. We've tried many different other staging systems, TNM, everything you could think of, the Barcelona clinic, everything you think of, but pretty much we all go back as surgeons to the MELD score to decide what can or can we not do. Now, what we used to do in the old days was you either resected them or you did nothing, or transplant them. And the reality is transplant is the best thing we could do. It's a 75% 10-year survival, and things are getting better every year related to both post-op care, complications, selecting the correct patients, the immunosuppressants. I remember when I trained in the 90s, the immunosuppressants, we would put people on 4 or 5 different immunosuppressants. Now it's down to 1, and they work tremendously. And so we want to first thing ask the question, is this patient a transplant candidate? Yes or no? And there's criteria for that. And what I would recommend is people look at the Milan criteria, like the city of Milan in Italy. But essentially it says you can't have a tumor greater than 5 centimeters, and you can't have 3 tumors adding up to greater than 8. And the reason for that is they've studied this and know that the risk of recurrence of the disease goes much higher when you are outside of that criteria. Now, what happened is, as our surgical techniques got better, our therapeutic techniques got better, the UCSF, University of California, San Francisco, actually looked at their data and noted that in some patients, you can actually extend that criteria. And the extended criteria are 6.5 centimeters, no tumor greater than 6, and again, 3 tumors less than 8. You wouldn't transplant a patient with major portal vein thrombosis, because we know those patients are extremely high risk for metastatic disease, hepatic vein involvement, things like that. Now, you can ask for from UNOS, which is the transplant society, or the organization that organizes transplants in different regions, but you can make a case to UNOS to transplant, especially in the young people. When we see people without cirrhosis, especially young women who develop a large hepatoma, some of these people will actually fit and get qualified for transplants. Now, before you transplant, you got to work them up to see, do they have metastatic disease? One of the things we do is a bone scan. One of the 2 top places hepatoma likes to go is the bone and the lung. So they'll get a chest CT if they haven't had that already. Sometimes we get an MRI and a CT. CT is really good for surgical planning because we get to see the different phases, the venous phase and the arterial phase, a lot better with more detail. And a lot of times these patients with cirrhosis have ascites, they're overweight, and they can't sit still because of their ammonia levels are through the roof. And so MRIs sometimes are not as good, but MRIs are a lot more sensitive at picking up hepatomas than CTs are. And so when you look at the tumor and you feel confident it is a hepatoma, question number 1, transplant, not transplant. If they are, you get them connected, you refer them to a transplant hepatologist to get evaluated. You get them staged, but you don't not treat. So we need to treat those tumors. And the nice thing about treatment of hepatoma nowadays is that we've come up with many local regional therapies. And Dr. Vogel, it sounds like, we'll be talking about yttrium and chemoembolization, bland embolization, microwave ablation. From a surgical perspective, resection is the next gold standard so far, but microwave ablation is catching up pretty well, that we're finding patients with hepatoma, metastatic colon cancer, other lesions, that if we can get a good ablation on a lesion less than 5 centimeters, that almost negates resection, especially if you're doing liver salvage. And in cirrhotics, we need to save as much liver as possible. That the imaging that you guys had showed a tumor in the center left lateral segment. In order to resect that, you'd take the whole left lateral segment, which you'd be taking segments 2 and 3, and that patient is probably going to lose within that resection probably 60%, 70% of good, well, somewhat good liver that they can use, non-hepatotic hepatoma liver. So we want to salvage that. So that's where ablation would come in. And usually my discussions are transplant, and then let's set them up for an ablation if it's doable. We can ablate fairly large tumors with overlapping ablations, but the microwave ablation, which uses microwave energy to heat up the water molecules that will heat it up to greater than 55 degrees centigrade, which nothing biologic can survive, will, based on time and wattage, will give you a certain sphere. And hopefully within that sphere, you've killed the tumor. And of course, you got to ablate slightly larger than the tumor in order to kill that tumor. If it's larger than that and it's palliative and we want to get at least try to kill as much as we can, we would then proceed with overlapping ablations, or we'll send them to interventional radiology, which we work very closely with, to do either an ablation followed by a chemoembolization or an yttrium 90. The nice thing about Y90 or yttrium 90, and Dr. Vogel will talk about it, it's a beta particle. It's extremely highly radioactive. It's so radioactive we can't really store it here. Anytime we have somebody, we actually have to ship it in. Essentially, if you took that jar of yttrium and blew it up downtown, it would essentially be a dirty bomb. So it's very highly regulated. It took us about 2 to 3 years to get everything in order to do this, probably back in 2000 and I would say probably 10 or earlier. In any event, you can treat a whole lobe with that. That's the nice thing. And these hepatomas are arterial fed. So using the arterial system, we can actually isolate the blood supply, hit it with yttrium. And what it does, it gives off such a high dose that that pretty much nothing survives. These hepatomas can be pretty resistant, but it actually works fairly well. So if we can resect the patient and this patient falls out of criteria for transplant or doesn't want a transplant or doesn't have the financials for a transplant, doesn't have the family support for a transplant, there's a lot of factors that go into that, then we would look at ablation and or resection. Again, the nice thing about tools now, anatomical resections, we can resect 2 segments out, which means we're not doing a Pringle maneuver where we clamp the porta to stop arterial flow and venous flow, and also clamp off the hepatic veins. We can do this with full flow to the liver while we're resecting. So it's like changing the oil while the car's driving. If that is an option, the 5-year survival on patients with resection is up in the 5 years, about 70%, 60-70% if we can do it. The problem with cirrhosis is no one can predict and no one can decide or figure out when the next hepatoma is going to arrive, whether it comes in 1 year, 2 years, 1 month, or never. And so that's the problem with resection, is that if we get them to transplant, that's great. If we can resect a simple resection without taking too much normal liver, that's what we do. Complications, obviously, these patients have portal hypertension. So before we go to resection or ablation, sometimes we get portal pressure gradients. That's measuring the portal pressure in the liver. Interventional radiology does that for me. They'll send down a catheter, a CVP catheter, through like a swan down a patient's neck in an internal jugular and measure the pressures around the heart and also at the liver. And if the portal pressure gradient, normally it's less than normal portal pressure gradient is less than 12. We've taken patients for ablations up to 26. Resection, you kind of want to be below 20, pretty, somewhere around 16 if you can, 17 at the most. Second problem, platelet counts. Most of these people are thrombocytopenic, so sometimes we have to give them platelets the day of surgery when we go under, and we don't give it to them until we're ready to cut or ready to ablate. We can do all the laparoscopy pretty safely. So the issues with cirrhotics are, one, too much portal hypertension results in bleeding. Number 2, thrombocytopenia and coagulopathies. And number 3, bile leaks, which really occurs because of the new tools we have. So the outcomes are pretty good, but it is a multidisciplinary approach. We work very closely with interventional radiology, GI, hepatology, medical oncology, and even radiation oncology. There's a lot of new techniques in treating hepatoma with external beam radiotherapy, which tends to work, especially those tumors around the heart, extending up from the vena cava. We've had some pretty remarkable reversals, and also tumors that we found were completely unresectable, and maybe they weren't candidates for yttrium-90, or the yttrium-90 didn't work. That external beam radiotherapy seems to help. It's a complicated patient, as I heard earlier. It's multifactorial. There's a lot of problems going on, a lot of social issues. Most of our hepatomas are related to Hep C and alcohol. We rarely get hepatitis B. And most important to understand that you can get a hepatoma from fatty liver disease. You can get a hepatoma from an adenoma in normal liver, and you can get a hepatoma in completely normal liver without cirrhosis, as well as in hepatitis B. So hopefully that gave enough background on surgery and the disease, and I'll hand it over to, I guess, Suji's up next, maybe.
Okay, great. Thank you, Dr. Galanopoulos. That was very informative, so we definitely appreciate it. Okay, and with that being said, we're scheduled to go on a 5-minute break. We are running a little behind, but I think maybe we should give everyone at least a couple of minutes if you need to maybe stretch your legs, and let's meet back in 2 to 3 minutes here.
Thank you.
Thank you. for those of you who are still here, some people asked me for a little lengthier break, so we'll take this up to 7:05, and I think Austin might have put that in the chat box. So if you need to do something else, you have a little longer period of time for a break here. Okay, everyone, let's get started again here. Let's pick up where we left off. So the patient is stabilized on the floor. Hepatologist, IR, and oncology are consulted for hepatocellular carcinoma. And with that, I'd like to introduce you to Dr. Reganti. Hello, Dr. Reganti.
Hi, everyone. Hi. So you can tell this is actually a case of Dr. Galanopoulos. You can see in his voice so much enthusiasm on this case. So anyway, so as a medical oncologist, because this patient has an isolated hepatocellular carcinoma, so our role is very limited in this, to be honest with you guys, because we usually get involved when the patient is not a surgical candidate, either it's because of the location, because of the hepatic reserve, because of the vascular involvement, because of the comorbidities or performance status, then they call us. If not, we are, like I said, for this patient, I mean, it's very fortunate this guy actually has an early stage cancer. Usually most of the time we identify the disease in later stage of the course. So for a 1.5 centimeter lesion, I mean, Dr. Galanopoulos went through all the criteria for surgical resection, and surgery or any local therapy is a bridge to transplant, because goal is to get the patient to the transplant if we can. Always have to remember that. And then either it's surgery or a TACE, which is a transarterial chemoembolization, or radiofrequency ablation. Sometimes we use them as a bridge, mainly the radiofrequency ablation and the TACE, and which Dr. Ogle is going to talk to you guys next. So Dr. Galanopoulos briefly mentioned about child puke score. And it's very important for a medical oncologist or a surgeon or a interventional radiologist to know about this, because most of our clinical trials, they can like enroll the patients based upon child pukes A, child pukes B, or child puke C. So the 5 things that you guys have to remember as the medical students is like, how do they score this? Is like by 5 criteria. One is albumin, INR, bilirubin level, hepatic encephalopathy, and ascites. Based upon these 5 things, there's a criteria that we can score them. So most of the clinical trials enroll patients with child pukes A. because I mean, for majority of us, it is for systemic therapy or for local therapy. So that's very important for you guys to know. And then there are other criteria that, more advanced criteria for specialized physicians like Dr. Galanopoulos, like MELD score, UCSF criteria. They're all important. But for as medical students, you guys need to definitely even kind of like memorize the child puke score. That's important for you guys. From a medical oncology point of view, in this case, right, like I said, my role is very limited right now because this is all like a local isolated hepatocellular carcinoma. There were multiple clinical trials have done to see if we can use systemic therapy in kind of like in making the local therapy more better. So they've used drugs which are targeted agents that we use for advanced stage hepatocellular carcinoma like sorafenib. So those drugs have been used in early stage for liver isolated hepatocellular carcinoma, maybe like giving it in combination with TACE, which is transarterial chemoembolization, which Dr. Ogle is going to talk about this next, or giving it along with radiofrequency ablation to see if the systemic therapy can make the local therapy more better. Maybe outcomes are good. So there are about 4 to 5 randomized clinical trials were done, and all of them showed no benefit. So that's one of the reasons why when we get a call from you guys, we always ask a question, did you call Dr. Galanopoulos? And then if he can't surgically remove the tumor, then we need to get Dr. Ogle from interventional radiology get involved, or even radiation oncology get involved, because like I said, our role in early stage hepatocellular carcinoma is very limited because even the trials with systemic therapy using it in early stage have showed no benefit. Basically like no benefit. That's one of the reasons. So I think that's it for this case from my point of view. So if you guys have any questions, I'll be happy to answer them.
Great. Thank you, Dr. Reganti. Next, we have, again, Dr. Vogel, who will give us an IR perspective on HCC treatment.
Great. Thanks, Arthur. And thanks, everyone, for the good discussion to this point. I think Drs. Reganti and Galanopoulos have already covered a lot of this. But the thing I'd like to emphasize with everyone is in looking at interventional treatment options for these patients, what we're really looking at always in America with these patients where hepatitis B is so rare, we're dealing with patients who have 2 diseases. And the treatment we decide on is largely determined by the status, not just of their hepatoma, but also how they're doing with cirrhosis, which is what all the various metrics like the child-Pugh calculation, or now the ALBI score, which is a little bit simpler, are trying to help us determine what route we're going to take this patient, and ultimately whether the therapeutic goal for this patient is transplant, which is the ideal, but to which there are a lot of barriers, or if this is all in the interests of palliation and making them more comfortable and helping them maximize their remaining time. So with that in mind, there are a number of treatment options. As a complement to what Dr. Galanopoulos does, thermal ablation is a very good option with image guidance in the liver. Frequently, and I think Chris would agree with me, frequently for posterior lesions or lesions that are harder to visualize with intraoperative ultrasound, or which aren't on the surface, certainly getting to these with an ablation probe is frequently no more difficult than doing a biopsy. And in fact, it's something that I'm moderately passionate about. There's a lot of data out there suggesting it's nearly as good as surgery in many cases, and the morbidity is usually substantially lower. So I am an ablation first guy. And the reason for that is usually that the transarterial therapies that we have at our disposal, chemoembolization, by which we put now most commonly doxorubicin-eluting beads into the arteries, specifically feeding the tumor, or sometimes this dirty bomb of yttrium-90 directly into the vessels supplying a tumor or into a whole lobe. The transarterial options are not liver vitamins. And all these people have underlying liver disease. So I know that even though the transarterial options may be the best option given an individual patient's disease burden, I do everything I can to try and save those bullets as long as I can. And I try to get as much done as possible with ablation. So certainly for the index patient in this case who has a 1.5 centimeter left liver lesion, that's about as good as it gets for me to do an ablation. And the way this typically goes down is I'll get a text or a call from Chris, and we'll just go over all the various factors concerning the patient's liver disease, the patient's anatomy, the patient's hope for transplant and therapeutic goals, and we'll sort of run down what we think the best options are. And I have a bias towards ablation, but once these people get one lesion, as Chris mentioned, they've proven that they're prone to develop more. And sometimes, you keep whacking at these moles with thermal ablation, and eventually it gets out of your hand if they don't go to transplant. And then you're left with the transarterial route.
Great. Thank you again, Dr. Vogel. And next we have Dr. Calatho, who's a hepatologist. And if you would, please, Dr. Calatho.
All right. Hello, everyone. Can you hear me?
Yes, we can.
Okay. Yeah, thanks for putting this forum together, because I think, first of all, from a hepatology standpoint, what I want to emphasize is when you take care of HCC patient, the most important care aspect is a multidisciplinary approach. And I think, from that standpoint, bringing all the specialists together to give a comprehensive, treatment approach is very important, because studies have shown, there are several, studies shown that when you have a multidisciplinary approach where everybody sit together, discuss the patient, come to a treatment algorithm that gives the best outcome, in the long term. Now, when you're talking about hepatoma care, I think the most important aspect is early diagnosis. So everybody has to be very familiar with the screening guidelines. Anytime you see a cirrhotic patient, always go back and check, when did they have the last screening ultrasound? Did they ever have an ultrasound or cross-sectional imaging studies within the last 6 months? If they haven't, please go ahead and check that, because early diagnosis is the key. And also, there are a couple of situations where non-cirrhotic patients can develop HCC. One is chronic hepatitis B. So you got to be very familiar with whom to screen. In men, it's age 40 and above. If they have chronic hepatitis B, even carriers, you should screen for hepatoma. The other one is in females, now you start screening at age 50. So when it comes to curative treatment for hepatoma, it is either surgical resection or liver transplant. And given the fact that most of the people who develop hepatoma are cirrhotics, you're probably going to look at a very small group of people who will be eligible for curative surgical resection. Most of them will be candidates for ablative treatment followed by liver transplant. So the surgical resection achieves the same comparative result as liver transplant in selected patients who are child-age cirrhotics with minimal or no portal hypertension. If they're not surgical candidates, then you evaluate for liver transplant. The transplant eligibility criteria has been widely discussed. Dr. Villanopoulos went over. It is the point I want to mention, like this patient, the lesion is 1.5 centimeter. I think for transplant eligibility, it got to be T2 lesion, that is 2 centimeter and above, right? So what do you do with this T1 lesion, that is who are not eligible for transplant at that point? Usually they'll go for ablative treatment, but there is also a strategy increasingly used in transplant centers where they won't treat the smaller lesions, allow this to grow to become T2, and then list them for transplant. But when you do this, you got to be very careful. Up to 20% of patients may become transplant eligible because the tumor can aggressively grow when you're in the interval imaging time, like, when you do between imaging, the next the treatment, the tumor can grow exponentially and patient can become transplant ineligible. So you got to carefully discuss this with the patient if you are taking the approach to allow the tumor to grow. Besides that, I just want to mention about the MELD exception points. As you know, if you have a hepatoma patient, once they're listed, after they've been in the list for about 6 months, they will be given MELD exception points, because if you rely on the lab MELD score, a lot of these patients may have reasonably preserved liver function, so MELD score may not be high. So because of for that, the UNOS allocate exception points so they can go up on the list. And the criteria keeps changing, but currently they are given the mean MELD score for that region -3 points. So typically, kind of that takes them to the top of the list so that they can get transplant within a reasonable time. Besides that, I think after the transplant, that we still have to continue to do surveillance on these patients for hepatoma recurrence, because even in patients who are transplanted within Milan criteria, there could be recurrence as high as 11%. If you're downstage and transplanted, the recurrence rate could be about 18%. So you got to do the surveillance, after transplant. Typically, there is something called retreat score, which takes into account the tumor load, microvascular invasion, and pre-transplant AFP level, and it's a calculated score, and that is usually used as a criteria how aggressively you have to do the surveillance for how many years. So I think that's all. I think I didn't cover much of other transplant criteria and everything, because it's been covered by other presenters. So let me know if you have any questions. But I think, and I just want to emphasize that when you see a cirrhotic patient, always think about screening, screening, screening. That is the most important message.
Great. Noted, Dr. Kalathi. Thank you for that. And with that, we're going to have Dr. Usera with pathology. He's going to talk about liver cirrhosis. And originally we had Dr. Usera speaking a little earlier in the program, but due to scheduling conflicts, we had to have him speak a little later. With that, Dr. Usera, if you can, please.
No problem. Thanks for setting this up, and thanks for having me.
Dr. Usera, I think you're muted.
Can you hear me now?
Yes.
Okay, all right. Well, I just wanted to start by saying thank you for having me, and I really think that this is an exceptional forum that you put together, and you really amalgamated the best assets in the community regarding liver care. So I'm honored to be on this panel. The first lesson I would say at this point is that in the spectrum, the timeline of our hypothetical patient here, if at this point you're consulting pathology, it's way too late. We really want to start with early diagnosis. So I wanted to circle back a little bit to Dr. Danko's talk. We introduced this patient from a psychiatric perspective, from a substance abuse perspective. But it's one thing for me to note is that cirrhosis is really an end-stage disease. Okay, it's all roads lead to Rome, meaning that all liver disease, whether it's autoimmune, whether it's alcohol-induced, whether it's viral-induced, whether it's any other form of disease, whether it's metabolic-induced, all of those can lead to cirrhosis. So I encourage people not to get hung up on a kind of a mental algorithm of cirrhosis equals alcoholic liver disease. It's important to know that there's a wide spectrum of diseases that can all end in cirrhosis. So at the point, as far as my role as a pathologist, on a liver biopsy, I can't tell you, by the time we're at cirrhosis, I can't tell you what the origin or the underlying etiology of disease really is. In rare circumstances, I might be able to, but hopefully what we want to do is have an early intervention, early diagnosis, and a biopsy can be helpful in circumstances where certain disease entities are being considered. And on that note, I did want to talk about a little bit about, we talked about alcoholic fatty liver disease leading to alcoholic steatohepatitis, which can lead to cirrhosis. And then historically, we have partitioned that from non-alcoholic fatty liver disease, which can also lead to steatohepatitis and cirrhosis. But in the interest of kind of avoiding stigmas, there's a international panel of experts has recommended that we change the terminology and the nomenclature to where we no longer refer to as non-alcoholic fatty liver disease. We now refer to as metabolic associated fatty liver disease. And I'm a big proponent of that change. So I encourage people to try to embrace that new nomenclature, new terminology. So my role right now is really to discuss what are the mechanisms of cirrhosis? How does this happen? The hepatic stellate cells, they're a endogenous cell that is populated in the liver, occupies the space of Dis. And they're kind of these star-shaped cells that normally their main role is to store vitamin A and to have hormonal communications with their ambient environment. But in the setting of injury, whether it's cytokines or inflammation or oxidation or what have you, those cells, they transform from kind of normal dormant stellate cells, they transform into myofibroblasts, okay? And they start depositing collagen. And that's it's like every other cell in our body that's responding to injury. When we want to lay down a scar, it's to try to ward off whatever the external insult really is. And that's what those cells are doing. And they start laying down type 1 and type 3 collagen. That's a unique type of, kind of collagen deposition. Most collagen in our body is type 4. So type 1 and type 3 collagen is relatively unique. As that collagen is deposited, it separates, it creates a widening, an ever widening barrier between the vascular supply and the hepatocytes that not only need the nutrients that the blood supply is supplying, but they also need to take their metabolic, the downstream metabolic contents, and they need to have a communication with the bloodstream. And with the fibrosis, that barrier becomes wider. And so it really disrupts the exchange of nutrients and the exchange of gases and the exchange of metabolites. As you can see in this picture here, you can see how wide, how expanded the interstitial component really is. Now, in response to injury, the hepatocytes can regenerate. We've known that for thousands of years. The old story of Prometheus is one of my favorites. Prometheus was someone who was punished by the gods on Mount Olympus. He stole fire from Mount Olympus, and he was punished by the gods to be chained to a rock, and they cut open his abdomen, and they let eagles feast upon his liver, knowing that the liver would regenerate, and it would be this kind of eternal torment of disease and torture. But the important thing to realize is that architecture is important. And if the hepatocytes regenerate and they continue to grow and replicate, if they don't do so with the appropriate hepatic architecture, then they're not really doing their job. And the best metaphor that I come up with is you can have 10,000 bricks. And if you arrange those bricks in the appropriate architecture with walls and ceilings and doors, you can have a home. But if you don't, then you just have a pile of 10,000 bricks, and it's not really functional, and you can't really do anything with it. And that's really what regenerative nodules represent in the liver. Is they are regenerative in response to injury, but they're not necessarily as functional as normal native hepatocytes. The other thing to consider is, where does the cancer come from? So in a cirrhotic liver, we have multiple nodules. We have small nodules, big nodules. Which is the one that is cancer? And from a fundamental perspective, you have to look at any cell type that is actively dividing. The more times it divides, the more likely you are to encounter some sort of chromosomal defect or genetic aberration that leads to dysplasia and malignancy, right? That's just playing the odds, right? That's why we tend to see cancers of cells that divide more rapidly, like skin cancers and GI cancers. So that's one of the reasons that dysplasia and dysplastic hepatocellular nodules arise, is in the setting of cirrhosis with rapidly dividing hepatocytes in response to injury, you're likely to come across a malignant transformation. Oftentimes those cells don't show morphologic. When I say morphologic, I'm meaning on a microscopic level. They don't always show a lot of very useful features. It's very challenging to make a diagnosis of a well-differentiated hepatocellular carcinoma microscopically. So that is a limitation of biopsy. And that's why, you know, I don't actually see them very often, because it's really best something that you want to observe clinically and radiologically, as our experts have referred to earlier. But there is, and so for that reason, you know, I also want you guys to consider that hepatocellular carcinoma very, very rarely will ever occur in the absence of cirrhosis, right? So hepatocellular carcinoma almost is inherently linked to a background of cirrhosis. There's very rare exceptions to that rule, and that would be the rare exception of the fibrolamellar variant of hepatocellular carcinoma, which we tend to see in young males and females in usually about the third decade of life. But hepatocellular carcinoma, because of its relationship to cirrhosis, it is the #1 cause of cancer-related mortality worldwide. We don't see a lot of, it ranks low in the list in the United States, but it's because of the burden of hepatitis B in Asia and subsequent cirrhosis that hepatocellular carcinoma is the #1 cause of cancer-related mortality worldwide. And I think that that's about all that I had to say. So I will shut up.
Thank you for that, Dr. Usar. That was very informative. So at this stage of the patient's care, the patient's liver lesion is definitively managed. He's advised to follow up with his primary care and addiction medicine, and which brings us full circle from outpatient into inpatient and back out to outpatient management again of the patient. And with that, I'd like to introduce you to Dr. Derringer, who will speak on behalf of Family Medicine Specialty.
All righty, thank you. So yeah, so I think when thinking, outpatient-wise, myself as a primary care physician, what's my level of involvement in this case? And really, it kind of varies. And I think my first point there is where's the location, what's the access to care? Here in Reno, we have a lot of great access to a lot of great providers who can help with a lot of the patient's need. But say you're out in Ely, Nevada, where you can be pretty limited there. What your level of involvement would change quite a bit. For example, during medical school, I did a 4-week stint out in Ely with a family medicine provider, and actually took care of a couple cirrhotic patients. And it was one of those, the family doc and the surgeon in town there were doing paracentesis on these patients just to help, because they didn't have any other access to other providers there. So where the level began, where our level of care is going to depend on the location there. For here in Reno, a lot of times when the patients that we're seeing, maybe I've taken care of them for the last 5 or 6 years. I've built a good relationship with that patient. So a lot of times my involvement is just them wanting to check in and talk with me about what's going on, what's their care, what's happening with the different providers out there. And what I also look at then is really the social determinants of health. Where is this patient living at? Where are they growing up? Where are they working in? How is that going to impact their ability to take care of themselves with a diagnosis of cirrhosis like this or cancer? And from there, that's where I really then develop my plan for helping these folks. When we go into special considerations there, a lot of times if we're reaching a point in that end-stage liver disease, there's not a lot we can do, and a lot of it's all supportive care. So I'm looking at how can I help the patient basically slow any progression they have there? How can I help monitor what their labs look like, what's their diet doing there, and how are they doing following up with those providers? So for me, if I'm taking, if we're at a stage where there's not a lot of options left and we're kind of managing the end of it there, I might take a little bigger role in watching their diet. What kind of vitamins are you doing? Are we doing supplementation with different vitamin stuff? Is there, to the point the liver's not producing much protein there, we're having trouble absorbing different vitamins there, then I might play a bigger role in the diet side of it there. Care compliance, I think, is a big one. This is one where I think, as a family medicine provider, I have a big area where I can help with this, because this is a patient I've built a relationship with. A lot of times these are patients that have my phone number or an email, and I may reach out to them. Hey, how's the appointments going? Are you making it to all your appointments? How's the family doing? And with that, I think just having an extra connection and a little support there, it can then help them get to the care they need that's outside my office. I do some basic lab monitoring. If someone's not active with a lot of specialists out there, then I may be looking at what's that INR doing? Are we more bigger risk for bleeding? And referral wise, if I've gotten someone from the hospital follow up there and they do need referral maybe to that oncologist, now they've been stabilized, we can help facilitate that. Probably one of the big areas that I've done a lot with, and this unfortunately I've done this recently with patients, is that end of life planning. What is it? Are they realistic in their expectations of how the disease is going to progress? What's going to happen with that? So how can I help facilitate that? Sometimes it's making sure, hey, what are your wishes? What do you want us to keep doing? Are you someone who wants to keep seeing everybody and doing as much treatment as you can? Or do we need to talk about, let's get our affairs in order, let's start talking about hospice. So some of the tools I have at my disposal for that in the office would be a PULSE form. It's a physician order for life-sustaining treatment. So this is a legal document I complete with the patient. It talks about, would they want CPR or not CPR? Would they want a feeding tube, artificial nutrition, IV fluids? So a lot of times that's a first step. And if we're to the point where we need to start talking about hospices, then how can I help transition and support that family to getting set up with hospice if we have reached that point? And a big factor is this is the mental health side of it. Especially when we're talking about alcoholic cirrhosis, maybe there's a lot bigger component of, and I think we're going to talk a little bit more about addiction side with Dr. Danko in just a minute here. But I look at how can I help support the mental health? Do I need to put them in contact with a mental health provider? Do we need to talk more about the addiction side of it? So really, I see my role as how can I best support that patient? Is it a medical side of it where I'm maybe following some labs, working through referrals, making sure they're getting the care? Or is that support side of it where we need to look more on the hospice route and how can I help the family through that? So really, I find my role changes there. Location will definitely change what I do in there. But I just really try to be flexible in how can I best help the patient. So that's what I got.
Great. Thank you, Dr. Derringer. Thank you for that. And lastly, we are going to have Dr. Danko again speaking about long-term management of these patients who, just because they had liver cirrhosis or even hepatocellular carcinoma, it doesn't mean that they necessarily stopped drinking. They had this problem before they went in. Yes, they're getting treatments. So what's the long-term management for that? Dr. Danko, if you would please.
Hi there. Can you hear me again?
We can, yes.
Wonderful. Thank you so much. Thanks for having me again for a second time. I think this has highlighted what a wonderful community we have and what a great collaborative effort we have in treating patients. And as highlighted previously, also, not every patient with cirrhosis or with liver disease has problems with alcohol use or with alcohol use disorder, but it is certainly something to think about when it comes to patients with cirrhosis and also with patients that don't have cirrhosis, because we have a huge preventative opportunity as well. So a couple of things that just in general I will say is that we should approach alcohol use disorder and those who use alcohol as a chronic disease. We should no longer be looking at it as it once was in a flaw-like way looked at, that it's a willpower issue or it's a lack of good character, people who drink alcohol. Instead, it really is a chronic disease that affects the dopamine pathway and doesn't leave much room for patients to make a choice about it. And therefore, we have an opportunity to come in and really give them compassionate care and opportunities for treatment that really work well. The U.S. Preventative Service Task Force does recommend screening for unhealthy alcohol use in all adults 18 years and older, and we have many different screening tool opportunities available also. And treatment for those who do struggle with alcohol use disorder should include both psychosocial treatment as well as pharmacologic interventions. And the treatment programs that I've had the opportunity to run and to help collaborate with, certainly we get these patients involved with behavioral health, and that really helps their care recovery as well. With respect to FDA approved medications, there's really 3 that are FDA approved at this time, and they include naltrexone, which essentially blocks the opioid receptor. It's an antagonist of that receptor. You'll also see naltrexone in one of the FDA approved medication categories for opioid use disorder. And so it does, essentially because endogenous opioids are involved in the expression and the reinforcement of alcohol use, blocking that receptor really controls cravings for patients. In addition, what I will say is naltrexone is very underused and underutilized. We have a huge opportunity, both inpatient and outpatient, to utilize this medication. And it has very, very small amount of side effects. If you do see the liver enzymes elevated, AST and ALT, then you certainly want to keep a close eye on those. And if they're trending up, then that's a time to stop naltrexone or to potentially cut down on the dosage. But I've only seen that probably in 1 out of hundreds, if not more than that, patients that I've treated with naltrexone. Additionally, we have other medications such as acamprosate, and we also have disulfiram, which essentially causes an unpleasant physiologic reaction. I will say that disulfiram, because it's negatively reinforcing, a lot of these patients with alcohol use disorder and addiction already have such a negative vision and have such a negative feel about themselves, and they're often stigmatized and not treated well. So really disulfiram should be reserved for patients who request that medication purely because it helps them and they are motivated enough to utilize that to their advantage in not drinking. But our big opportunity, I would say, is naltrexone. And again, what I will say is that patients are very highly affected with alcohol use and alcohol use disorder. And we have a huge amount of treatment options available. When we look at multiple different studies that have come out, the relapse rates for people who drink alcohol and then thus go back to drinking alcohol are across the board exactly the same as relapse rates and compliance for medications with diabetes and asthma and many of the chronic conditions that we treat on a daily basis. So the bottom line from my perspective is treat these patients with compassion and know that we have a very big opportunity to treat a lot of folks, both preventatively and in chronic disease management with medications like naltrexone and early referral, and also taking an appropriate social history and making sure that we're capturing that problem. So that's really my side. I'm happy to talk much more about medication options and treatment opportunities and also doses of naltrexone if anybody's interested in that in the discussion board. But thank you again for allowing me to participate in such a wonderful panel.
Thank you, Dr. Danko. That was very informative. And with that, we are going to go into our Q&A session. If anybody has any questions, I can't see the chat box right now, and so I'll let Austin read off any questions from there. Otherwise, if anybody has any questions, you're more than welcome to chime in and ask your question. But I'll get us started here. I want to ask a question to all the panelists, so you can just unmute yourself and answer this if you can. And Dr. Vogel briefly spoke about collaborating with their counterparts when it comes to various treatment options and how do you come to a conclusion as to what's best for the patient. But since one of the goals of this panel is to highlight the interplay between the various specialties, I'd like to go back to that and get a sense of when it comes to making a finalized decision and when there are subjective ways of looking at which treatment is right for a patient. Who ultimately makes this decision? Is it the patient or is it up to the physicians to really come to a consensus and offer their best opinion to the patient?
Sure, I'd be happy to address that because that's really probably the single most critical question in setting the course. And you can look at all the algorithms that are out there, the Barcelona algorithm, other algorithms, but really you don't have any good idea about what a patient might be best served having therapeutically until you sat down and you've talked with them and you've talked with their family and you make sure they understand that they have a disease and it's likely to be not one, but two chronic diseases. And it's a process of helping them manage it and get to the best end they can get to as they define it. And the algorithms do not cover that. And you certainly run into patients who just want their doctor to tell them what to do. But when I get back into a corner and in that situation, it's only after having spent some time with them and their family that I'll actually make a recommendation. And it would, there's no circumstance under which I do that without consultation and collaboration with other specialties.
Can I just chime in on something?
Of course.
One thing that I see, I review cases for the state, some of the patient complaints, etc. And one of the things that is not brought up, is not written in the chart frequently, is the statement of "you're going to die from this," death. I think that's something that everybody avoids or doesn't put in, but I think it's critical for the team, the multidisciplinary approach, that we make a statement that without intervention, this intervention is going to buy you time for the transplant. Without a transplant, your longevity is X, Y, whatever. But we have to make sure that we tell the patients that their risk of dying of this issue is high. You need to write that down someplace so everybody's on the same page. And I think, Aaron, that the paperwork that you have is great. I think that sets the tone. But I hope by the time they get to you, they've already had a chance to think about some of this stuff. But I think we all need to start talking about mortality and death when you talk with these patients.
Yeah, this is Dr. Collis. I want to piggyback off of Denny's comment there. We go through this in the hospital all the time because we're dealing with those that are generally decompensated if we're having the conversation in the hospital. And so often they really don't have a good feel for the seriousness and the short-term outlook of their condition without intervention. Because in the interest of trying to be kind and compassionate and empathetic, we inadvertently candy coat everything. And patients and families often get the wrong idea. That's why probably the most critical question you can ask after you've had the beginnings of a conversation is, what is your understanding so far of what I've said to you? And then listen. Do they say, well, I'm probably going to be fine, but you want me to have this procedure that has a 10% chance of killing me, so I don't want to do it? Well, what they didn't hear is if you don't have that procedure, you have a 99% chance of dying in the next 3 months. And I think we can do a much better job of that. So, full circle, it's not as cut and dried as you may think. This does not follow a guideline protocol. As you heard from multiple other physicians here on the panel, this has to be individualized, and you have to, number one, make sure the patient has complete information. And as Dr. Yamamoto said, that includes mortality information and not candy coating it. And then I think the second most important point is once you realize, or you're sure that they understand that information, that we really sit back long enough to listen to what they really want and value, and not project our values and our judgments on them. Oh, this is an 80-year-old alcoholic. He's toast. We shouldn't offer him this. He's not a candidate. Whoa, 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 whoa. That's not our call. We deal with data. We give the data to the patient in the way they can understand, and then we listen to the patient, and then we discuss the options. Thanks a lot.
Great. Thank you, Dr. Callister. Thank you, everyone, for answering that question. And we'll open up the forum for anybody else that has any questions.
Is it okay to answer one of the questions that's on the chat box?
Yes, please go ahead, Dr.
Well, there's a question that says, what is the proper discharge protocol for a patient who has gone through alcohol detox? So a patient who has completed alcohol withdrawal within the hospitalization, and we certainly see this quite a bit, it's a great opportunity to assess where that patient might be at with his wants to go for further treatment. Some patients will need something like inpatient treatment, a more intensive protocol, especially if that patient has had to detox from multiple substances, opioids and alcohol, or alcohol plus benzodiazepines or other substances. In some cases, patients are resistant to going to inpatient treatment or simply don't have the pay source or the opportunity. In that case, you can offer them outpatient treatment. I really think that treatment works best with behavioral health, and I can give you guys lists of places that are taking referrals in the community. And naltrexone is really going to be a great option for patients, especially if their liver enzymes are in acceptable range. And it can be started at about 50 milligrams once daily. And really, like I said, doesn't have a whole lot of side effects. You just have to be careful that the patients haven't received opioids within the past week, or you can precipitate an opioid withdrawal when you're giving naltrexone to them.
Excellent. Thank you, Dr. Danko. Any other questions out there?
We have in the chat box, there was somebody put up too many cooks. Somebody made a comment about having too many cooks in the, did I read that wrong? I realize that there's so many different subspecialties here. I think I'll say this, that I look at this as a fine meal. Everybody brings something different to the meal. Their expertise, and it's the organization and the concert effect of this, everybody bringing what they do best to this, to then have a conversation to have the best outcome. I think that I speak for the panel, not any one of us has the single answer to this. It really takes a coordinated effort. As Dr. Danko said, we have such a great group of people in town or any community to do that. So I look at like this as a fine dinner. We're all bringing a list of bits and pieces. I'm bringing the appetizer. Dr. Danko's bringing the dessert. That kind of things. You coordinate all that.
Indeed. Austin, did we have any other questions in the chat box?
I think there was another one about how would you approach a conversation if the liver issues are caused by alcohol use. I think approach it very much the same way as you would approach somebody who has any kind of medical condition, someone who has COPD that still might be smoking, someone who has diabetes that has difficulty taking or complying with medication regimen. Certainly not in a way to say, well, you need to stop drinking alcohol because it's killing you, but instead to say, where are you at with the alcohol? Kind of a motivational interviewing type of a technique. Do you have interest in stopping alcohol or cutting back on your alcohol? And if so, how can we participate in a conversation about getting you referrals and resources to help? So really an open-ended conversation that's non-judgmental is going to be your best approach. And then enticing that if we do give you treatment, there's a possibility that your liver will get better or that certain other conditions may get better.
Excellent. Thank you again, Dr. Danko. Okay, and do I hear any other questions? If not, with that being said, I'd like to thank everyone, especially all the specialists that took time out of their busy schedules to be present here today. I think I can speak for all of us when I say we are going to take a lot away from this. This was very informative. It's one thing to see a specialist speak about their trait and what it looks like to manage for a patient versus seeing the interplay between all the different specialties. So I definitely am going to take a lot from this event here. So I want to thank everyone for being present, and I want to extend a special thank you to Dr. Danko, who was so instrumental in finding some of the doctors that we were lacking to speak here. So I really appreciate that. Thank you. And thanks to everyone else for being present. This was a great turnout. And if this is an indicator for things to come, I think we'll be having more of these types of events in the future. So thank you, everyone. Thanks for being here.
Thank you for having us. Have a great night.
Thanks, everybody.
Thank
I'd
you.
also like to announce before the students leave that the Family and Internal Medicine Student Interest Group had the most participants and therefore will be allowed an extra $100 of funding for next semester. So congratulations, good representation.
Congratulations.
Woo!